going to give us a presentation on what causes dystonia, which is a tough topic. So take it away.
Mm-hmm. Thank you very much for the introduction, Rose, and I would also like to thank the organizers very much for inviting me to give this talk here. So like Professor Santos already mentioned, since 5 years we have a new classification of dystonias, where dystonias are classified along different axes. There's a clinical axis where we look at the age of onset, bodily distribution, temporal pattern, and also whether or not there are any associated features. And in the second axis, that's also a very important axis, where we look at the etiology of the dystonia. Yeah. So nowadays we make a distinction between, on the one hand, isolated dystonias, where dystonia with or without tremor is the sole motor feature. On the other hand, there's a large group of combined dystonias, where dystonias are part of a more broad movement disorder, where you have other accompanying movement disorders like chorea, for example, and there's a lot of neurological diseases which fall into this category. So as I just told you, the etiology of dystonia is an important classifier for dystonia, and we'll go over the different possible causes of dystonia. I immediately have to admit that in many patients we unfortunately don't know what's the cause of their dystonia. It's especially the case in many cases of adult onset, focal or segmental isolated dystonias, like many patients with cervical dystonia. In these cases, the dystonia can be sporadic or can be familial, but in many patients, even if we do genetic tests, we don't find the cause. It is possible that many of these dystonias will later on be reclassified as inherited, as we see that over the years new dystonia genes are being recognized. An older term, the use of which is now discouraged, is primary dystonia, which used to be used for dystonia that could be idiopathic or genetic. But because of this duality, we now prefer to talk about, on the one hand, idiopathic, on the other hand, genetic dystonias. And we also like to talk about isolated dystonias versus combined dystonias now. First of all, if a patient presents with dystonia, the first thing we want to exclude is whether or not there is any nervous system pathology. And for that, an MRI scan is a modality of choice because it is the most sensitive way to look for nervous system pathology. And there can be different problems in the nervous system. There can be a problem of degeneration. For example, there can be a neuronal loss in selective areas of the brain, like in patients with Huntington's disease. There can also be static lesions, like, for example, a stroke in the basal ganglia can give rise to later on development of dystonia on one side of the body. First of all, I would like to talk to you about the acquired dystonias. So there's many different reasons why one can acquire a dystonia during life. So there can be a problem of perinatal brain injury, and these patients, if they have, for example, an anoxia during birth, they can develop a dystonic cerebral palsy. Several central nervous system infections can also give rise to lesions that can cause dystonia. I will talk you later in more detail about different drugs that can also provoke dystonia. There are several toxins that can also give rise to brain lesions, especially in the basal ganglia, that can then secondary give rise to dystonia. I talked to you already about the example of vascular lesions, like an ischemic stroke, that can give rise to dystonia. There's also some paraneoplastic phenomena, so antibodies that are caused by some types of cancer that can react against certain brain cells, and these can then cause dystonia. And all kinds of brain injuries can also cause dystonia. I would now like to talk a bit more about the drugs that can cause dystonia. Dopamine receptor blocking agents, especially antipsychotic drugs, can give rise to a dystonia. On the one hand, there's the possibility of developing an acute dystonic reaction. In 50% of the patients, it develops within 48 hours of the administration of the drug, and in 90% within 5 days of treatment. It's typically an acute dystonic reaction that will go away within 1 month, and usually already after a few days the reaction is completely gone. Typically these patients have painful ocular deviations. They can develop an oromandibular dystonia and also a cervical dystonia that can be very painful. It can be caused by several drugs, also by some antiemetic drugs that have also dopamine receptor blocking properties. Much more severe, because the effect is long-lasting, are tardive dystonias that can be caused by also dopamine receptor blocking drugs. These tardive dystonias can occur as focal, segmental, or even as a generalized dystonia. It's more common to see it in young men, and it can be all kinds of dystonia that can be caused by these drugs. It can be blepharospasm, it can be severe oromandibular dystonia. There can be several types of cervical dystonia that can be caused by these drugs, and also more generalized forms of dystonia. And these tardive dystonias usually appear after these drugs have been taken already for several months, and in most cases several years before the symptoms appear. And that's a problem, that in the beginning it looks like the drug is really beneficial to the patient, but then after some years patients develop these side effects that will then require other treatments. So it's mainly antipsychotics that will give rise to these dystonias. Some antiemetics can also give rise to it, and also select calcium channel blockers like cinnarizine and flunarizine. And the mechanism behind these tardive dystonias is that these drugs block the striatal D2 receptors, and that gives rise to a dopamine receptor hypersensitization that then gives rise to these tardive dystonias. That can be a very serious problem, and it's unfortunately all too common, because many of these drugs are used quite often, and therefore I think it's very important that antipsychotics are used only in cases where it's absolutely necessary, for example in patients with a very severe schizophrenia, but that their use is preferably avoided in patients with a depression that can be treated with other medications that can't cause these tardive dystonias. There are several risk factors for tardive dystonias, like advanced age in women, the fact that the patient also has a bipolar disorder, a history of diabetes mellitus, brain trauma in the past, alcohol or drug abuse, or a prior adverse reaction to these drugs. If the patient has once developed an acute dystonic reaction, they're certainly at risk of later on also develop these tardive dystonias if the use of the drug or of a similar drug is continued. A special group of acquired dystonias that we have gained more and more insights into in recent years are autoimmune dystonias. These dystonias can be caused by antibodies that people develop, and these antibodies react with certain cells in the brain and will then give rise to dystonia. Very often there's also a lot of other symptoms like other movement disorders, also autonomic features like rising and falling blood pressure, for example. And I've listed here 3 types of antibodies that particularly can give rise to these autoimmune dystonias. You have the NMDA receptor antibodies, where you quite often in these patients see oculogyric crises, where there are painful eye movements. There's also a specific syndrome that is linked to re-antibodies, where patients develop a jaw closing dystonia with episodes of laryngeal spasm. And these re-antibodies are caused as a paraneoplastic phenomenon by certain types of cancer that can give rise to these antibodies. All of these forms of dystonia are really rare, but it's important if a patient presents with a new dystonia to think about these causes. There's also glycine receptor antibodies that can give rise to lockjaw, so a kind of jaw closing dystonia that really resembles tetanus, and they can also give rise to other diseases that are part of the stiff person spectrum disorders, where there's not only a focal dystonia but also more generalized hypertonia. So that for the acquired dystonias, an important group and an important cause of dystonia are genetic causes. It's only a minority of patients in whom the dystonia is inherited, but novel genes are described every year. And the classification that is used is the DYT classification. But since 2 years, we have some new designations for these genes. I will focus on a few genetic dystonias that are a bit more common than others. Here you see in this table which are different genetic syndromes where dystonia can occur. And if patients have an isolated dystonia that is generalized, then the most frequent gene that is mutated is DYT1 in the new classification. That's DYT-TOR1A, named after the gene that is mutated. If the isolated dystonia is focal or segmental, then the most common cause, if it's autosomal dominant, is DYT6, which is now called DYT-THAP1, also after the gene that's mutated. And then there are also some combined syndromes that I will come back in a few minutes on. So if we look at the autosomal dominant dystonias, so these are dystonias that are caused by genes that are transferred from one generation to the next, and where if you have the gene, you have a quite high likelihood of developing a dystonia. So very often in these families, there's not only one member with a dystonia, but there are typically several members in the grandparents, the parents, and the children that do have a dystonia. The penetrance is incomplete, so that means that not everybody who is a carrier of a mutation in these genes will also develop a dystonia. There are some people that carry the gene and that can then transfer the risk to their children that don't develop the dystonia themselves. The penetrance for DYT1 is something like 30%, for DYT6 it's something like 60%. So DYT1 typically has an onset early in life. It begins typically as a lower limb dystonia, but then later on develops to a generalized dystonia. But there is quite some heterogeneity here. So also in these families, you sometimes see patients with a DYT1 mutation that only develop a focal dystonia. DYT6 is typically an adult onset dystonia, where there is a prominent craniocervical dystonia with also very often a striking laryngeal involvement. Another group that in recent years we have gained more insights into are the paroxysmal dystonia. So these are dystonias that come on very sudden as a kind of attack of dystonia, and very often there's also other movement disorders like some features of chorea or dyskinesias. And there are three different types of paroxysmal dystonias. There's the one that are exercise induced, so that develop after a prolonged exercise. And these are caused typically by mutations in the GLUT1 gene. GLUT1 is a glucose transporter. Glucose is the sugar that cells in the brain need to function well. And when there is a problem with the glucose transport, some people will develop these exercise-induced dyskinesias with also some dystonic features. Another gene, the PRRT2 gene, can give rise to kinesiogenic dyskinesias or dystonias, where these dyskinesias develop after very short bouts of exercise. And then there are the non-kinesiogenic dyskinesias that are caused not by movements, not by exercise, but for example by drinking coffee and other stimulants that can have an effect on the nervous system. And these are typically caused by mutations in the MR1 gene. We now know that each of these genes can also cause each of the other types of paroxysmal dyskinesias and dystonias. So there's definitely some genetic heterogeneity and overlap between these different syndromes. There's 4 dystonia syndromes that are quite clearly delineated. There's the early onset generalized isolated dystonia, so without other accompanying movement disorders. And these early onset generalized dystonias are typically caused by mutations in DYT1 and less often mutations in DYT6. If you look at adult onset focal or segmental isolated dystonias, then these are usually sporadic. And these are the dystonias that are only occurring in the cervical muscles and give rise to cervical dystonia. They can give rise to blepharospasm or a writer's cramp, and they typically have an onset in the 5th decade of life. And there's 2 other specific syndromes with a genetic cause, and these are dystonia Parkinsonism and myoclonus dystonia. Dystonia Parkinsonism is a form of dystonia where you also have features of Parkinson's disease, like rigid muscles, slower movements. And there's 2 big categories in this group. You have on the one hand the dopa-responsive dystonias, caused by most often by mutations in these 2 different genes. And on the one hand, you have young onset Parkinson's disease. So if Parkinson's disease develops at a really young age, then the first presenting symptom can be
So all's good?
You're okay?
Yep.
Okay,
Okay.
excellent. And okay. Welcome anyway. So, in young onset Parkinson's patients, the first presenting symptom of their disease can be a dystonia before other Parkinsonian symptoms develop, and it can be that for quite a long time that the dystonic features are most prominent in these patients. And these young onset patients that develop Parkinson's disease at a really young age, they typically have mutations in different genes like the Parkin, PINK1, or the DJ1 gene. Myoclonus dystonia is another specific syndrome where patients develop dystonia, but on the other hand, they also have myoclonus, which are a kind of lightning-like jerks that occur mainly in the cervical muscles and also in the arms of the patients. So it's a very classical and recognizable phenotype that's typically associated with mutations in the epsilon sarcoglycan, but there is, as we now know, significant clinical and also genetic heterogeneity. So we now know that this phenotype can also be a presentation of several other gene mutations, and we also know that with a certain gene mutation there is also quite some variability. There is also incomplete penetrance, so not all patients with a mutation in one of these genes will develop myoclonus dystonia. Now I would like to take a step back. We focused on some causes, also we focused specifically on genetic mutations, but we know that in many patients there's also other causes. We suspect that there's also susceptibility genes that so far are not well known, and we know also that in some patients environmental factors will also play an important role. And then if we look at the level of the brain, we know that the several structures there are very important in the pathophysiology of dystonia. And in the brain we know that there's especially an impaired inhibition, which gives rise to an overactivity of the different muscles, and that gives rise to the dystonic contractions. We know that there is abnormal plasticity, abnormal signaling between different brain cells, and there can also be a sensory dysfunction that gives rise to the dystonia. And in this slide, the sensory misrepresentation is shown, and it's something that we typically see as a mechanism in focal task-specific dystonias, like, for example, musicians' dystonia, where musicians strain certain muscles so much that there's a kind of overuse, and that we think, and it has been shown in research, that the organization in the brain, where, for example, in normal subjects you see that there's different areas where the neurons are that give signals to different fingers, and the borders between these areas become more blurred in a patient who has then a dystonia, and with different treatments you can try to retune it to solve the dystonia. We know that especially the basal ganglia, so that's a structure with different nuclei in the middle of the brain, that's very important in dystonia. And this part of the brain receives signals from a lot of other brain areas that have been implicated in dystonia, like the cerebellum at the back of the brain stem, and also the cortex. And these give different signals where we know that different neurotransmitters, so different signal molecules, are important, where we know that there's an important role for dopamine, like we know from the dopamine receptor blocking agents that can give rise to dystonia. Cholinergic mechanisms are important, and we also know that GABA, which is an important inhibitory signal molecule, can also play a role in dystonia. And especially the cholinergic interneurons in the basal ganglia are important. We know that in normal conditions they secrete acetylcholine, and we know that in patients with dystonic mutations, for example here with a DYT1 mutation, you don't have the normal inhibitory mechanisms anymore. There's too much acetylcholine that is secreted, and these neurons are overactive, which can give rise then to overactivity in the muscles and the dystonia. But about these molecular mechanisms, I'm certain that Professor Goodchild will tell us a lot more later on today. So dystonias are more and more seen also as a spectrum, where in patients that develop dystonias at a young age, we know that there is a high chance of having an underlying genetic mutation that causes something to go wrong with basal ganglia plasticity. And we know that the older the patient is when the patient develops a dystonia, the less likely there is an underlying genetic mutation. And we think that environmental factors like overuse in musicians' dystonia, writer's cramp, overtraining of certain muscles plays a more important role. So to conclude, still today many cases of dystonia are idiopathic. So in many patients we don't know what's the cause yet. Genetic causes are rare, but new genes are regularly being recognized, and we know that there's quite some clinical and genetic heterogeneity, so that one gene can cause different types of dystonia, and one type of dystonia, like the myoclonus dystonia, can be caused by mutations in different genes. And lesion studies and also functional studies of genetic dystonias, they have led us in recent years to gradually increasing insights into the pathogenesis of dystonias, and we can all hope that these increasing insights will also lead us to novel and better treatments in the future that will hopefully be able to better treat the different dystonias. Thank you.